And do you have faculty who you would consider your simulation champions? Can you just name them off the top of your head? I can, but I'm not going to call their names as I call them every year for certain training. But is there one that comes to your mind? Is there something about their teaching style that you really appreciate when they're doing debriefings that you want to share with our audience?
And then each program kind of has their own. So I would take for EM, it's Dr. Negrani. Mm-hmm. He's got a wealth of sim experience. He's one of those easy emergency medicine, so he likes on the fly. Mm-hmm. So we work with him to break him down and say, we need this written out. Mm-hmm. And then with surgery, Dr. Foxhall has been a huge champion. He's gone and got his ACS simulation conferences, so really taking it to our surgery to the next level of sim. I am Dr. Umana I've done faculty development sessions for her, and I'm very good. And then Dr. Prasad with psych. So all of them have really taken, even our palliative and hospice. Mm-hmm. When we had Dr. Pickett, we've done some really impactful sims with all of them. And then, I left off Dr. Newton. Can't leave off Dr. Newton.
I love it.
I think one of the most important things with all of those is that they have made sure that the residents know that sim is a safe learning environment for the residents, and that they've created this culture of trust. So even if you make a mistake in sim, it's okay. You're going to learn from it. So I think that's something that they all have in common.
For us at Northeast Georgia, that just hits me here is when we have new physicians come in and new chiefs that have just finished a residency. And the first question I ask when I'm bringing them through is, how much sim have you had? And none of them have had what we have. And so the fact that every one of our programs has taken sim, that it's part of their curriculum, which isn't true in other GME residencies across the country. Each one's a little bit different because it really hasn't become standardized. So each one of our programs, and even within our fellowships with Dr. Eglum, and now we'll work with critical care with Dr. Emlingham, is they see the benefit of sim. And even though they haven't had it, they want to say, we're going to put this into our residencies and fellowships. That makes a statement for what we're doing here, and that we're becoming the model for other systems.
And I think what's very unique here at our facility is the interdisciplinary, interprofessional training that we do here. So how can simulation educators effectively address and manage the challenges of interprofessional team dynamics during a training session? Because I know when I used to do this in times past, we would have the physicians break off, do their own debriefing, respiratory do their own debriefing, and nursing. But what are some of the ways that you manage the challenges as it comes to interprofessional team dynamics during any of the training sessions? Do you have any specific training sessions that you want to talk about where you have not just physicians in the room?
We do a lot of interdisciplinary simulations that have from PCTs to nurses to physicians to respiratory, all working together on one simulation. And I think kind of one way to address challenges is to have really clear expectations and roles as they go in the room. So everyone kind of knows what they're doing when they're going in the room so they can really work as a team.
And that's a big one. So in at critical care sims that we'll bring nurses down from the floor. Mm-hmm. So the residents then are actually working with nurses that they see up on the floors. And the nurses are able to bring in their day-to-day knowledge of. And so we've had a couple when we first started this doing the stroke, one of our educators was on the rapid response team. And so we were doing the stroke, and this is with Dr. Kruer, if I can say his name. Just did.
It's fine. He emailed me yesterday.
As we were doing it, he goes, no, I want the residents to learn how to do the NIH scale. Yes. And Hadassah came in and said, they don't do that. We do that. And so he was receptive and said, okay, let's change this sim. So that's the impact of having the interprofessional. And now we've done it with nurse leadership, nurse residency impacting PCTs. As we look at this team-based nursing, we need to integrate this. And then as we're doing the rapids now with the in situ sims of making sure that we just don't have nurses and techs, that we get the physicians to come in and do it as a group, because that's how we work on the floors. And so the faculty have said that we'd never had this before, and now they make these big requests is we need 5 nurses and we're going to do this and a respiratory therapist. And we figured out how to make it work. And it's different rather than the old way we used to do it was I'd have 4 residents say, okay, you're the nurse, you're the RT, which distracts from their learning.
Yes.
Because they're going, I don't know what a nurse does. And so now with the resources we have here are able to actually put them in that. We make it more realistic and take away that disbelief of, okay, I'm with this nurse and I'm going to go the way I would. Hey, I need you to do this. Okay. And then we work with the nurses so that if a resident's going down the wrong path, we put an earpiece in them and we're talking to the nurse saying, yeah, why don't you do that? And then they can talk to us and say, should I step in? So we help guide, do this facilitated learning as faculty are watching it. So it really helps guide the sim go in the direction we need it to go. And that's a learning aspect for the faculty of utilizing the resources to the best rather than us having it already and never gets used.
And I do want to bring up one scenario that we always do every year where we introduce actually the chaplains into our education with our residents as it relates to ethical issues. Any thoughts that you have on that particular simulation that I'm referring to? I know you all know what I'm referring to. But I'm used to dealing with nurses, respiratory therapists, physicians. But this to me was a challenge bringing in, I didn't realize, we have chaplain who need education as well. So that's an interdisciplinary, interprofessional simulation that we do surrounding that particular case. But anyone want to talk about that in particular?
I think that particular case is fantastic. But it also brings the team together, but it is also educating the chaplains, because even though their support role in this particular simulation, they're coming in and learning as well. So that debrief is wonderful. So it's just giving that idea of what are your resources. So when those physician residents walk into a simulation, they also know that they have resources throughout the organization. So even though we're focusing on one skill in a simulation or, 3 or 4 objectives, they know that they have other resources here. And what are those resources? So that's really working with a team of call your friends, right? Those safety toolkits, those type of things are all happening in that simulation. So we get some really good feedback from the chaplains. They love coming over.
We can't say what that sim is because we're about to do it. And we don't want
I know.
back to hear about it ahead of time. But then they'll know what we are doing in there.
But one other thing, too, is when you work with that team, and Corey brought this up a little bit, and we talked a little bit about the pre-brief. This is one of those situations where that pre-brief is very, very important because you're setting the stage and you're setting the safety. So our simulation lab is very passionate about having that safe learning space. And that is really the benefit of simulation is because it is a safe space. So you can make those mistakes. And then so when we're doing that pre-brief, we're all talking about this is a safe space. So those simulations working with the team is a safe space, meaning whatever goes on in sim stays in sim, kind of like Vegas. Because when you're working in sim, you're going to be working with these people outside in the patient care units. And you don't want to be like, well, they didn't really do well in that sim, right? So that's what we really talk about, and we foster that culture over in simulation is safe learning. Whatever happens here happens, and we're learning. So when you go out to the floor, hopefully you'll have a very positive experience taking care of those patients.
For some of those, that can trigger that we do. So having faculty and then the sim educators in that control room watching becomes really a critical component to being able to observe. So like the one case we're talking about, we've seen where it gets it might trigger a resident or the learner in a way that maybe is previous life experience or something that happened that day. So that's why the debrief is such a critical component, both the pre-brief. So all of them really can't put any more importance on any of them, but they have to all happen. Because the debrief is where you kind of close the loop and allow them to come back is, that really upset me, or we've had one, so that would never happen. And then another resident go, that happened to me yesterday.
Right.
And now they go, oh, I didn't realize that. So we do another one like that with utilizing our patient experience people from if they have a different foreign language that we need to. So we have them, and a lot of the residents don't even realize the resources they have available. And then with our patient experience people, for them to be able to say, hey, I'm your here person, and I speak these languages. Here's all the languages we have available. Here's how to use the tablet if you're going to go that way. So we put that into a sim so they all get that experience, rather than it being their first time with a real patient and going, I don't know how to talk to my patient.
Yeah. So I want to close our discussion talking about artificial intelligence. And are you utilizing it anywhere in the sim world? So if I'm a new faculty person coming into the sim lab, you've introduced me to your area, you've walked me around, you showed me the mannequins, you didn't say anything about the moulage room. Then you're telling me about your standardized patients that I have here, the resources, the debriefing. What else? Is there any artificial intelligence, virtual reality that you also utilize within your sim center that you would like to share?
Yeah, I can talk about AI. I don't know if you want to talk about VR, Corey, with the stuff that you've done.
Yeah, so we do have a lot of AI, and we know that it's constantly evolving as well. So we want to make sure that we're kind of staying on top of that. We know what's coming out and what's new, whether that be with like all the AI that can now kind of recognize what you're saying and respond to it. We have a new mannequin that does that.
Oh, really?
So it'll actually listen to your conversation and can respond appropriately to the conversation in the room, which is really interesting and terrifying at the same time sometimes. But we also have virtual reality. So you're putting on the headset and you're putting yourself in that perspective of either the patient or maybe even the healthcare professional, and you're immersing yourself fully into what they see and what they experience. So I think that that's just another great way of being able to do the simulation, a different teaching modality that is very impactful.
Can we go back to the eavesdropping mannequin? It sounds a little weird to me and spooky.
They don't eavesdrop.
Is there a technical term? Like, how do you set that mannequin up? That seems
called
fascinating
so
to
that
me and
with that,
concerning all
yeah.
at the same time.
So
please
it's
share with our
a
audience.
lower level of what they call conversational AI.
Interesting.
So there's out there's Dragon software that will dictate, like if I'm talking and do that. So conversational AI it's programmed with the responses, and so it recognizes, like if I go, hey, how are you doing today? And I say, well, and then whatever that has been programmed in it with the conversational AI will come back. Oh, I'm not doing well today. I'm having some chest pain. Oh, when did that start? What's your name? So and it's only as good as what's been programmed into it. So they'll program all the questions that it wants us to recognize. So that's kind of the limitations right now with AI is the AI we have isn't really learning AI like we see in movies and stuff. It's what we call narrow AI, which is only as good as what we program it. But every sim company now is coming out with what they call AI. And so we kind of added to say, okay, does this meet our learning objectives? And then we have to, for us to learn how to use it the best and then train the faculty. Whereas the most useful for us is actually in like our ultrasound. It has our ultrasounds we're using on the floors and that we have in the sim lab have AI components that will do measurements and ejection fractions that now the residents are doing the little scrolling on the ultrasound thing. The AI software within the ultrasound is doing it. But in sim, we have to teach them how to use it. So that's the other part of the really critical part of AI is institutions, hospitals, look at incorporating AI into different modalities within the system. We use sim to teach them how to do that. And outside of AI, you would say like telemedicine. We'll do a telemedicine sim, say, now how do I do patient encounter over a computer screen and actually make that connection and ask the right questions? Because it isn't part of medical school or residency until now that it's a critical part. And that's where really AI is going. within the sim world, it's still at a lower level, but it's enhancing what we can do. So some are using AI to write a sim, but with the narrowness of AI, you still have to go into it to make sure it was clinically correct. But it can save 40 hours. You write me a sim, and here's the vitals I want, here's the case, put it into a format for me, and it will spit it out, but it might it does what they call hallucinate. So it makes up things. It makes up vitals. If I didn't put them in there, it will tell you. So, but it has saved you time. Like now I have a good template, and I can work off of that.
So what ethical considerations should faculty keep in mind when incorporating AI into simulation training?
Big one is is it matching best practices, and is it clinically relevant? And those are the ones where we have to really do just as much homework with something I've developed in AI to make sure, is it accurate? Rather than it saving all this time, AI gave me this, and then you do it and go, because you can have AI write you a program if I want to put it into the simulator, but it may not do what you think it is supposed to do. So right now, AI within the sim side is still kind of the more what's coming up is conversational AI, and that'll be a huge one for us. Even with the VR, if I can wear the Oculus, do our VR program, the ones we do with our diversity and inclusion, and have a conversation with the patient and have it going through, now you've made it more realistic that I can actually what we call bring them into like being at a movie or a theater where you get sucked into it. Now it becomes realistic, and they're having emotional responses, which makes that debriefing. Even with the VR, the debrief is a critical component for us. And you have found that with some of the DEI ones where it's triggered. That if we didn't have that debriefing, we wouldn't have been able to bring them back to kind of that level ground in that safe environment where they might have walked away going, I'm so upset and this is horrible. And but AI is still in its infancy, just kind of as SIM is in its infancy as we are building it. But I think the next 3 to 5 years is going to be a lot of fun.
I love it. So quick question. I know there's certification that you can get a credentialing in simulation. I know as for simulation educators, is it the same if I'm a medical faculty? Can I get the same type of certification in simulation if I have an invested interest to study
Right
more?
now there's 3 different levels of certification. There's the certified healthcare educator, which would be any clinical realm from an EMT. It really doesn't go based on what level they are. It's the same curriculum, or they go take a test. Corey just was our latest one who got her, we call it cheesy.
Okay.
And then there's the one for a tech, which is the CHSOS. And that one deals more with the technology side of SIM, but they can get certified. And then there's an advanced level, which is someone that's been doing it for, I forget how long, but it's like it usually has at least over 8 years of SIM experience. And that gets more into the operational side of SIM. And then some programs have started fellowships in simulation, which are really geared for clinicians. That side of it, but it's a building profession as it comes in. They said in 2012 was when the first certifications kind of came out, and that dates myself.
Well, but should not outdate yourselves. I believe we have a accredited simulation center here. So if I was a faculty person, is there anything you want to brag on? How did you get your accreditation? How new is it? And who cares that you're accredited? Like, what does that really mean to us as a new faculty person coming in?
So accreditation for simulation is best practices. So you have been certified by the Society of Simulation, which is your international society for simulation that anyone can join. And they come in and look at your program, make sure you meet the criteria, and it's really best practice. So what are those things out there that everyone's doing in simulations? So making sure we have a safe environment, vetting all of our simulations, making sure we have appropriate equipment, safe equipment, things like that. So we were accredited in fall of 2023. So that was a huge.
And with this podcast, faculty development is part of that accreditation of now, are we following best practices and how are we incorporating faculty development, that they're not coming in cold, kind of, we said at the beginning, that what are the things we've put in place, and now like what we're working together on for faculty development to enhance that part. And then, we got recognized by Becker's as one of the top 34 SIM centers in the country. That was same time frame, October of 2023. So now we're working on a new accreditation with American College of Surgeons. So, but it all points us to that direction, kind of same as DNB, that we're following a minimal standard that's been set by, this Society of Simulation and then American College of Surgeons. That you start then, how do we go above that? And then keeping that side of it, and it helps us kind of show that we're doing things that others aren't doing. That's the other part.
Well, I want to thank you all for joining me today for our podcast just focused in on simulation. But my last parting question is, if I'm new to Northeast Georgia and I'm a faculty member for GME, who do I get in touch with if I want to get a tour, meet the standardized patients? Like, who do I call? I know it's not Janine, so
Either one, all of us. So.
all of you. So
Any one of us.
Any one of you. What's your name again? Just go through the list. What's your name? You're Jim.
So I'm Jim. And if you go on to our NGHS website and go under into GME and go into just search simulation, it'll bring you to our page, and that will give you the contact of who to contact, and that would probably go through our information site, and it shows our forums and our videos, and we'll have a tour up there pretty soon of our 360 tour, so that's very cool.
And if you like social media, we're on Instagram as well.
Well, I want to thank you all for joining me today, and I look forward to if there's any other conversational pieces that you think that faculty should know related to simulation. This will be a part of our platform that we can just talk to them about it. So thanks for joining me today.
Thank you.
Thank you.